So thank you everybody for joining this evening, and to anybody who is watching this on record at a later date. My name's Deb Lees. I'm clinical lead pharmacist for respiratory in the medicines optimization team at the ICB, and I'm also co-clinical lead for children and young people's asthma, and spend one day a week working with Asthma and Lung UK on improving asthma and all respiratory outcomes across South Yorkshire. So today I was asked to talk to you a little bit about the new NICE BTS sign guidance. I have made a decision to focus on adults and adolescents tonight because sometimes it's a bit too much to include children as well, and a bit too much to take in. So we're focusing on adults and adolescents 12 and above today. I've called this presentation the Asthma Revolution. I don't mean this kind of revolution. I hope people don't start fighting. But what I do mean is a significant shift in the way that we think about asthma and the way that we treat it going forwards, because I do think that we are at a turning point. And before we go into the kind of what's and the wheres and etc. of the guidelines, I think it's really important to have a little think about the why. Why are we looking for a significant change in asthma management? Why are we, wanting to introduce these new guidelines and get everybody working to these new guidelines? And I think this chart on the left-hand side of this slide just pretty much says it all. So this is asthma mortality rate, and what you can see is the United Kingdom is right at the top of that list. So this is Western European countries, and we have the worst asthma outcomes of the whole of Europe. And it always astounds me when I see this data, and it isn't shifting. It hasn't shifted. I've had sort of older data as well, which has said exactly the same thing, because we have a brilliant health service and we have access to all the best medicines. So to have the worst outcomes just really shocks and upsets me, to be honest. And any of you who were kind of around and interested in respiratory care back in 2014 will remember the Why Asthma Still Kills report, which was the National Review of Asthma Deaths. So that's over a decade ago now. And what that highlighted to us back in 2014 was some quite significant issues with respiratory care, in particular asthma care in the UK. So it highlighted things like people weren't having asthma reviews, people weren't getting personalised asthma action plans, and it also highlighted some quite big considerations around medicines, and it being the first time really that it was highlighted to us that excessive use of short-acting beta-2 agonists was a real concern. So a lot of these people who died and were studied as part of this report were excessively using salbutamol inhalers, the blue inhaler, short-acting beta-2 agonists, and underusing preventive therapy. So there was a huge underuse of inhaled corticosteroids, so that anti-inflammatory treatment to actually treat the symptoms, to treat the inflammation that's driving the symptoms that the patient is having. And last year, back in 2024, Asthma and Lung UK produced the 10 Years Gone report, which was a report that was released on the 10th anniversary of the National Review of Asthma Deaths. And, what you would have hoped is that this was going to say things like asthma care has improved in the last 10 years. We've seen a real reduction in asthma mortality in the UK. Sadly, it didn't show us that asthma care had stagnated. It didn't show us that it got better. It showed us that it's got worse, and actually asthma deaths have increased by 25% in the UK since the publication of the National Review of Asthma Deaths. And these are all headlines that I pulled from the press last year. And to me, any death from asthma, which is a completely reversible condition, is an absolute tragedy. And in particular, when we see stories of children dying of their asthma, I just think it's an absolute never event in my eyes. So thinking about treatment, so people often say to me, but, we had guidelines that told us that the first step of treatment of asthma was salbutamol on its own for ages. So, why have things changed? Why are we not doing things the same way anymore? But asthma treatment is a real change in paradigm. And 50 years ago, we believed that asthma was a disease of bronchoconstriction. So therefore, it made perfect sense that the treatment would be with bronchodilators. However, we moved on from that, and we've moved on to knowing that asthma is an inflammatory airways disease, and therefore we have to treat it with anti-inflammatory medicines. And we are at a stage now where we have biologic therapies for asthma as well, so we can actually get people into clinical remission from their disease with these therapies, and they're amazing, but we're not going to go into those in detail today. We're going to focus a little bit on ICS formoterol. So I think that is the paradigm shift, really. So just to give you a little bit of a history of ICS formoterol in the management of asthma, the first ICS formoterol combination inhaler was licensed back in 2001, so 24 years ago now. And we had the first maintenance and reliever therapy licensed and launched in the UK in 2007. So maintenance and reliever therapy, which we're going to talk about a lot today, is not new. It's been around for 18 years. The problem is it's been hidden in the depths of our guidelines, and it's probably been kind of the fourth or the fifth thing that people have thought about doing with people with asthma. And that's where the change really is happening, and we'll talk a bit about that shortly. And our most recent change to ICS formoterol is that in 2023, we got the first anti-inflammatory reliever therapy launched in the UK. So this is a single inhaler combination of ICS formoterol, budesonide formoterol in the case of anti-inflammatory reliever therapy. Here's your inhaler, go and use it. Use it when you need it, just like they would do with their blue inhaler usually. We have that facility to do that with an ICS formoterol combination inhaler now. But asthma as an inflammatory disease is not a new thing. It was reported on as early as the 1860s. So we have known that there is an inflammatory component in the pathophysiology of asthma for a long, long time. We've just focused very, very much on this kind of reactive asthma management and kind of the focus on bronchodilators, but we need to move away from that now. So I'm going to introduce you now to SAD SABA. So I tell everybody who will listen to me about SAD SABA. So SAD SABA came about because I wanted a cartoon image to have in a presentation. And when I Googled, and it was before I'd got used to using ChatGPT and things like that, they were all happy and smiley. And I couldn't understand the imagery around salbutamol in the fact that it was depicted as something that was good. And that's not how I perceive it. I perceive salbutamol, if somebody with asthma is needing to use their salbutamol inhaler, that is a real sign to me that their asthma is not well controlled. And actually we should be doing something about it. It's a really risky perception for someone to rely on that inhaler, because they might relax their airway smooth muscle a little bit with their bronchodilator, but the underlying inflammation that's driving the symptoms that they're getting is continuing. That continues to narrow the airways, and it will leave them susceptible to further symptoms and a possible asthma attack. So back in 2020, off the back of kind of the National Review of Asthma Deaths, and off the back of all the kind of talk around SABA usage, the Sabina program was launched and published. And the Sabina program was a global program which looked at the effects of overuse of short-acting beta-2 agonists in asthma. And what that highlighted to us was that overuse was associated with an increased risk of exacerbations and an increased risk of mortality in asthma. So if you think about the old steps of the BTS pathway, which was a long time ago, where we had that first step of salbutamol and then add on an ICS and then add on a LABA and that kind of thing, no matter what step of that treatment pathway you were on, if you were using a high amount of salbutamol inhalers, you were approximately twice as likely to have a severe asthma exacerbation. And by high salbutamol usage, which was defined in this study, is anyone using 3 or more salbutamol inhalers in a 12-month period. So none of this kind of 12, one a month's fine, none of this 6 or more. It was actually anyone who was using 3 or more inhalers was approximately twice as likely to have a severe exacerbation. So low use was only considered people who were using 1 or 2 inhalers in a year. And that's how we need to think about salbutamol going forward. So the problem that we've been left with is we had that National Review of Asthma Deaths where over 10 years on from that now, people say, why did the National Review of Asthma Deaths not make a difference? Was it not the shift that we needed? And I think the problem is our guidelines have struggled to keep up with the movement and the shift towards different treatment regimens. So we had in 2016, the sort of new version of the BTS asthma guidelines. And that took out that first step of salbutamol on its own. So we thought, yes, we're getting there. We've removed this step of salbutamol on its own. People are not going to be managed on SABA monotherapy. A year later, in 2017, NICE decides it's going to publish its separate national guidance for the management of asthma. And they put salbutamol on its own back in. And they also created a lot more confusion because there were different things said at different stages. So I think that confusion and the fact that our guidelines have really struggled to keep up has caused the fact that things have got worse and not better. But we're here now in 2025. And we do have a new national guideline that was published in November last year, and it's a joint guideline between BTS, NICE and SIGN. So everybody is now singing off the same hymn sheet. But just taking you back to 2019, so taking you through the time a little bit. So 2019, GINA, who is the global initiative for asthma, they don't class themselves as a guideline because they're global, but they do advise and they do update their advice every year. In 2019, they suggested a very fundamental change in the management of asthma, and that was that nobody should be treated with a salbutamol on its own, the short-acting beta-2 agonist on its own, without a concomitant prescription for an ICS, an inhaled corticosteroid. And locally, we started to try and shift our guidance off the back of that advice, but we still waited another 5 years for our combined national guideline to join in on the party. But we have that now, and that's really exciting because I think this is the shift that we need. And they made a very bold statement in that guidance, and it wasn't a recommendation, it was a do not prescribe. It was a very clear do not prescribe short-acting beta-2 agonist to people of any age with asthma without a concomitant prescription for an ICS, which basically says that our national guidance is now saying that it is not appropriate to prescribe salbutamol monotherapy to treat asthma. So we are at a time of significant change in terms of our asthma management, but it's really, really important that every touch point of this guidance kind of understands what's happening there. So you guys in community pharmacy are so important to this because you're the ones that are going to identify these people who are excessively using their SABA inhalers, and you can help give them the right advice going forward and really help change things. Because the guidance they reviewed the evidence. They said that the clinical outcomes were poorest in all age groups for people who were using SABA alone, although it was the cheapest option to use. SABA, it's become quite a popular inhaler to prescribe because it's pretty cheap as well. But they also looked at all the other evidence. They looked at things like the National Review of Asthma Deaths, and they looked at things like the Sabina study, and they took into account all of that. And despite the fact that that was considered the cheapest, it was certainly not assessed as the most cost effective because people die if they use salbutamol on their own or they excessively use their salbutamol. So that is why they have made the recommendations that they've had, and we're going to go and talk on a little bit more about that now. So as I said at the beginning, I'm going to focus on adults and adolescents 12 and above today, because it's a bit much to kind of try and cover all the other age groups of children, because each of the algorithms has their own nuances and differences. So we're going to focus on adults and adolescents 12 and above. But if you find this interesting, I'm more than happy to come back and do a separate session on children. So thinking about our adults and adolescents, the next couple of slides that you're going to see is my interpretation of the guideline, because I'm a very visual person, and I don't particularly like wordy 100-page documents, if I'm honest, and who in which clinician has got time to digest all of that. So I like to try and get all the information on a page if I can. So this is my interpretation of the treatment algorithm for adults and adolescents 12 and above. And this is where NICE, BTS and SIGN have made another quite bold statement. And that is that they have put all their eggs into the ICS formoterol basket as far as management in this age range is concerned. There is no alternative treatment pathway recommended for this age group, because the evidence is so strong for the use of ICS formoterol combination therapies that they did not want to muddy the waters by making an alternative recommendation. So this is the kind of route that we're trying to go down with this age range. So what you'll see at the top of this is that what they're saying is there's no salbutamol in this treatment pathway at all. Offer low-dose anti-inflammatory reliever therapy with ICS formoterol. Anti-inflammatory reliever therapy you'll hear me refer to as AIR. That's what it's become kind of fondly known as. So this is using an ICS formoterol combination inhaler. It's the budesonide formoterol combinations that have the anti-inflammatory reliever therapy license, like Symbicort Turbohaler 206 or Fobumix Easyhaler 164.5. And here's your inhaler. Use it when you need it. It's as simple as that. So this is a kind of change in the inhaler rather than the behavior, I guess, and it's kind of mimicking natural human behavior to just take something when they need it. So that is what the first step of our treatment pathway is. However, the guideline does say to us that if we've got somebody who presents to us as highly symptomatic, we should go straight into maintenance and reliever therapy. So that is where they're taking the ICS formoterol combination inhaler, usually once in the morning, once at night, and then that same inhaler as a reliever on top of for extra doses if they need to. And for anybody who's kind of more symptomatic, I would kind of consider that anyone who's having symptoms 3 or more times a week, or their asthma's causing them to wake up at night, or they present and they're in a position where they need a course of oral corticosteroids. Absolutely, we should go straight into that maintenance and reliever therapy. But the whole idea of AIR and MART is that patients can move up and down throughout the pathway with the inhaler that they've got. So actually, if they get symptoms more frequently, they can step up to MART. But if their symptoms, say for instance in the summer, aren't as bad, they could step down to AIR at that point, and then they can step back up to MART. The flexibility of these dosing regimes is great. They can step up to a moderate dose maintenance reliever therapy. So that would be 2 puffs of the inhaler in the morning, 2 puffs at night, and then additional doses up to the maximum. The maximum varies depending on the combination, and we'll talk a little bit more about that shortly. After that point, so what you'll probably see is people out there with, getting a steroid, a SABA, a leukotriene receptor antagonist like montelukast. They might have a separate inhaler for a long-acting muscarinic antagonist as well. People get all these add-ons. Their steroid dose is being escalated sky high, and they're still out in primary care, and they're still suffering with their asthma. And one of the things that this new guideline has done is given us some very, very clear points of referral into specialist care, because as I mentioned earlier, we have access to biologic therapies that can do fantastic things for asthma patients. So why are we leaving people suffering out in primary care, getting repetitive symptoms? The problem with that is that if we're not managing their asthma asthma well, they end up with airway remodeling, they end up with fixed airways disease, and that's effectively COPD that they can end up with if their asthma is not very well managed. So the guideline tells primary care at this point to check a FeNO level. So FeNO is fractional exhaled nitric oxide, and that's a level of inflammation. It shows the amount of inflammation that's happening in someone's airways, and to also check their blood eosinophil count. So what we're looking for here is evidence of eosinophilic airway inflammation happening for that person. And if either of those is raised, we should be referring them into that point. So if they're uncontrolled on a moderate dose MART regime and they have either a high blood eosinophil count or a high FeNO level, then they should be being referred in so that we can investigate what's happening there. Of course, we do expect them to have their inhaler technique checked and their compliance checked, etc., before that happens. We need to just make sure that they are taking what they say they're taking and they're taking it properly first. But if all that's checked, then we're going to refer them in to specialist care. But if neither of those is raised, then we can think about adding on add-on therapies, and that's either going to be a leukotriene receptor antagonist or a long-acting muscarinic antagonist as a separate inhaler on top of the MART regime. When we're adding on therapies, we do it for a trial period, so probably about 8 to 12 weeks. It's really important to assess whether people have actually responded to that treatment. For example, montelukast, not everybody responds to montelukast, and also montelukast can be associated with some quite nasty neuropsychiatric side effects. So it's really important to have that as a trial and review that trial at the end of it, see whether they've improved. If they haven't improved, we stop it and we can try the alternative. If they have improved a bit, but they're still symptomatic, we can add the other one in. If they've improved fully, great. They've reached the therapy level that's going to control their asthma. But of course, if we've got to the point where we've added both of these add-on therapies in and the patient is still symptomatic and still uncontrolled, we refer them in to specialist care. What you will probably not see is the 12 to 17-year-old group getting the LAMA added on in primary care, but because most of our respiratory paediatricians across the region kind of feel that that is something that should be added on in secondary care, but you obviously will see people getting it prescribed because and you will be dispensing it for people because they will then go on to their repeat prescriptions once they've been seen in specialist care. But we generally advise that primary care don't start the LAMA in that age range, but you will see it started in adults as well going forward. So what about people on existing pathways? What about people out there who are kind of already being managed, in inverted commas, with the treatment pathways, with more traditional or conventional treatment pathways? What the guidance says is, if it isn't broken, don't fix it, kind of thing. So if somebody's got on a treatment regime already, whatever that might be an ICS with the SABA as a reliever, they might have add-on therapies on top of that. If they are well controlled, then you don't have to change it. But we have to define what we mean by well controlled. And actually there is a bit of a normalization of asthma symptoms that goes on. People with asthma, healthcare professionals, if you've got asthma, it's normal for you to cough, it's normal for you to wheeze, it's normal for you to be breathless. We need to move away from that acceptance of symptoms in asthma, and actually we should be looking for complete control. So we should be looking for no breathlessness, no coughing, no waking up at night, no limitation on activities to get that complete control. And certainly if anybody is having to use a reliever inhaler 3 or more times a week, or their asthma is causing them to wake up at night, that's not well controlled, and we should be thinking about moving them on to an alternative ICS formoterol combination therapy, usually as MART. So if they're out there and they're on SABA on their own, get them all onto anti-inflammatory reliever therapy. Nobody should be left on SABA monotherapy. If they're out there and they're uncontrolled on a low dose regime, then we should be thinking about shifting them over to a low dose maintenance and reliever therapy. And likewise with a moderate, we should move them on to a moderate dose maintenance and reliever therapy. If they're uncontrolled on any high dose therapy, we should be getting them into specialist care. We shouldn't really be seeing people getting escalated to high dose inhaled corticosteroids these days without being investigated by secondary care. If you've got people who are on like various add-on therapies, we are advised to think about what benefit did that add-on therapy have when it was first started. So have a conversation with the patient. Did you actually get benefit from montelukast when it was started? If they didn't get much benefit from it, or they don't perceive much benefit from it, the guidance advises us to think about stopping that whilst we transfer over to a maintenance and reliever therapy regime, because you might find actually that a maintenance and reliever therapy regime is sufficient on its own and they don't need those add-on therapies. So into the nitty-gritty of ICS formoterol combination inhalers. So I like to think of these kind of flexible treatment regimes like AIR and MART as putting the pieces of the jigsaw together. So in one hand I've got my piece of the jigsaw, which is my inhaled corticosteroid. So that's my anti-inflammatory treatment. That is what is going to treat that inflammation that's driving the symptoms that the patient has. That's my treatment for asthma. But in the other hand, I've got the other piece of the jigsaw, which is formoterol. You might know formoterol as a LABA, a long-acting beta agonist. Now, I refer to formoterol as a FABA, a fast-acting beta agonist, because formoterol acts in around the same amount of time as salbutamol, so it's around 1 to 3 minutes to have its effect. And so therefore, you know, it's fast-acting. It can be used as a reliever. It can be used in acute symptoms. So we can be really confident in the fact that should a patient have asthma symptoms, that formoterol will help relieve those symptoms. But you know what? When they take a puff of that inhaler, they're secretly getting a little bit of extra steroids. So when their symptoms start, they increase that steroid dose that they're getting. So they dampen down that inflammation. And that's why these treatment regimes can reduce exacerbations quite significantly. And I think it's really important to be, as healthcare professionals, to be really confident about selling these new regimes. Change is challenging for people. It's totally understandable that people with asthma become attached to that blue inhaler. But we know, and we have so much evidence to show us that it's not safe, to rely on that. In fact, the MHRA released a drug safety update earlier this month, which highlighted the risks associated with short-acting beta agonists. So we know it's not safe. So I like to talk to people not about the fact that I'm taking something away. I won't say I'm stopping your blue inhaler or I'm taking your blue inhaler away. I will say I'm upgrading your inhaler in the same way as you might want to upgrade your mobile phone to the latest iPhone or the latest Android, whatever takes your fancy. We are doing that with their inhaler when we're giving them an ICS formoterol combination inhaler, and it's not about cost, because a salbutamol inhaler costs £1.46. Some of these ICS formoterol combination inhalers cost about £28. So it's not about cost. This is about saving lives, and so that's the kind of angle that I try and use with people, to say, this is an upgrade. This is going to treat your asthma well. It's going to work quick, so it's going to give you that relief when you really do need it, but it's actually going to treat your asthma, and it's going to help you long term as well, by using that inhaled corticosteroid at the same time. And these are low doses of inhaled corticosteroid that we're using with people, so people can be assured really that the risks associated with low dose inhaled corticosteroids are absolutely minute. They're really, really safe inhalers to take. So thinking about anti-inflammatory reliever therapy. So as I mentioned, this is a single inhaler and it's used as needed. So what we would advise is you just take one puff as needed in response to symptoms. If you get any more symptoms, you can take another puff. You can usually take up to 6 puffs at any one time, and you can usually take up to 8 puffs in a day in a 24-hour period. But for a limited period, probably about 2 days, people can be recommended to go up to 12 puffs. Now, you might be thinking to yourself, well, she's talking about high dose steroids and not getting people on high dose steroids. Surely that's a lot of steroids. Yes, it is if they take 8 puffs in a day. But what we generally find is with people for whom anti-inflammatory reliever therapy is appropriate for, they don't need to take excessive doses, because guess what? They're actually treating the inflammation that's causing their symptoms in the first place. So they're not needing to take the number of puffs that they would have done of their salbutamol inhaler in the past. And the studies highlight to us that actually the average daily dose there's 4 big studies done of anti-inflammatory reliever therapy: Sigma 1, Sigma 2, Novel Start, and Practical, and a huge meta-analysis of all 4 studies. And what that highlighted to us was that the people in the studies, they were taking about 50 to 100 micrograms of budesonide a day. So it was like tiny doses of budesonide daily that people were actually taking when using this treatment regime. So we don't see excessive use. But what we have to do is we have to safety net against excessive use. So my advice to GP practices and anyone who's prescribing really is to put an issue duration on these inhalers so that we can pick up when they're coming to and asking for them a bit more frequently. So for anti-inflammatory reliever therapy, what I would normally say is something between 60 and 90 days as an issue duration, to kind of pick up if that's being used more frequently than we would expect it to be used. So that's a kind of a good idea. And what I would normally say is to anybody, if you ever get to the point where you're needing 8 puffs in a day, seek some medical advice quite soon, because that's a sign that your asthma is really, really poorly controlled, and we need to do something about it. And certainly if they're needing to use excessive doses and extra doses for 3 or more days in a row, that's a sign that they should be seeking urgent medical advice at that point in time. So the safety netting is really important, but we generally don't tend to see that excessive use of these treatments. So benefits of anti-inflammatory reliever therapy. Well, I talked about those 4 studies and the meta-analysis of those studies, comparing as needed anti-inflammatory reliever therapy with budesonide formoterol to somebody using as needed salbutamol. There's a reduction in severe exacerbations of 60 to 64%. And that is just huge. Like that is a no-brainer to me. That this is the reason why we are doing this. It's such a huge reduction in exacerbations. And then comparing it to people who were taking like a fixed daily dose of steroids, say morning and night, and using salbutamol as a reliever, people who were using the anti-inflammatory reliever therapy, they were getting either the same level of control or better level of control. One of the studies, Practical, was a more real-world study, which definitely showed better level of control. But we were seeing that with much lower doses of budesonide. So that 50 to 100 micrograms per day daily dose of budesonide. It's one inhaler, so it's really simple for the patient. They're not having to remember to carry 2 inhalers around with them. They're not having to remember how to use 2 different inhalers if they've got 2 different inhaler devices. So it's a really simple regimen. Here's your inhaler, use it when you need it, mimicking that natural behavior to just respond to symptoms. It's 1 prescription charge. So I've seen people in the past choose between their brown and their blue inhaler because they can't afford to pay both prescription charges, and they have to make that choice. What do they pick? They pick the blue one because that's the one they perceive that they get the benefit from, because it's a bronchodilator and they feel a bit better after they've used it. But it's not the one that's treating their asthma. So we take that choice away when we put them 2 pieces of the jigsaw puzzle together in 1 inhaler. We're giving them both, and they only have to pay 1 prescription charge. And as I've mentioned, we're changing that inhaler rather than the behavior. So it's useful for patients who have more infrequent symptoms, I would describe. So I always call these the I only have asthma whens, and we've all come across I only have asthma whens. I only have asthma when I exercise. I only have asthma when it's cold or when it's hot or when the pollen count's high or when I go to my auntie's house and my auntie's got a long-haired cat and I'm allergic to the cat. We've all come across people who say, well, I only have asthma whens. And that's where anti-inflammatory reliever therapy sits. It's perfect for those people. It's also really useful when compliance to a regular daily dosing regime is a problem. So as I've mentioned, you don't have to be compliant with this because it's an as and when treatment. And it can be used from 12 years of age, and it is our budesonide formoterol combination inhalers that are licensed for anti-inflammatory reliever therapy. So that's things like Symbicort Turbohaler 206, as I mentioned, and Fobumix Easyhaler 164.5, which are the same strength. I'm sure you know that they are the same strength. It's just the way the MHRA changed the way that dosing had to be depicted on inhaler devices at a particular time. So anything that was after that time has to show the delivered dose. Moving on to maintenance and reliever therapy. Now, we do have more inhalers licensed for maintenance and reliever therapy. So we also have the beclomethasone formoterol combination inhalers. So things like Foster, Bibecfor, there's loads about at the moment, Lufabec, etc., etc. They're beclomethasone formoterol. The important thing to remember about beclomethasone formoterol combination inhalers is that they are only licensed from 18, so they can't be used in that 12 to 17 age range. And as I mentioned earlier, this is a single inhaler for daily treatment, and that daily treatment is usually 1 puff in the morning, 1 puff at night. But actually, you know, if it works best for the patient, then they could take 2 puffs in the morning if that's when they're going to remember to take their dose, or 2 puffs in the evening. And actually, what's really interesting is a new study that's come out which has highlighted that actually taking steroid dose early to mid-afternoon is actually showing improved lung function. So I think this is really interesting, particularly when we're talking about adolescents, because I think, you know, adolescence is a great time to think about changing onto a dry powder inhaler, because they are not going to lob their spacer around with them in their blazer pocket at school. You know, that's just not going to happen. So a dry powder inhaler is probably a great thing to start thinking about, because they don't have to carry a separate device around with them. But also thinking about anti-inflammatory reliever therapy and when they could take their daily dose. I don't know a lot of teenagers. I have one. I have a teenager, and I know that she is always rushing on a morning. So, you know, she doesn't have asthma, but if she did, she would probably forget to take her daily maintenance dose of inhaler on a morning, because she wants to stay in bed as long as possible, and she wants to just rush and get ready and go out to school. However, she might remember when she walks in the door after school. And lo and behold, that happens to be exactly the right time that study showed us is a good time to get better lung function improvements from our inhaled corticosteroids. So could be perfect for adolescents to do that. So as I say, the low dose is 1 puff in the morning, 1 puff at night, and then additional doses up to the maximum. For the budesonide formoterol combination inhalers, as I've mentioned previously, it's usually no more than 8 in a day, but you can go up to 12 for a couple of days if necessary. But for the beclomethasone formoterol combination inhalers, it is only up to a maximum of 8. But again, remember those safety netting. If anyone's using 8, that's a sign their asthma is not well controlled. We need to see them. If they've got to the point where they've needed those maximum doses for 3 days, I would be saying urgent advice at that particular point in time. And issue durations when we're prescribing are really, really important. So for a low dose MART regime, I would probably say around 45 days is probably a good issue duration for an inhaler that's got 120 doses in it, because it will allow some use of extra additional doses, but it will pick up if those inhalers are being ordered more frequently. When you're explaining these inhalers to people, quite often you might hear, oh, it's not working. It's not working, because they're used to that blue inhaler. They're used to using it very, very badly without a spacer, and they're used to it feeling the hit at the back of their mouth or on their tongue. And actually, that's what they feel as it's working. That's not working because they're not getting any of the drug into their lungs where it needs to be. And they might not, particularly if we put them on a dry powder inhaler, get that feeling anymore. So it's important to explain to people that, you know, you won't, with a dry powder inhaler, you won't feel that hit on the back of your throat, but that doesn't mean that the inhaler's not working. It probably means that it's working better because it means that the drug is actually getting into your lungs and not you know, hitting the back of your mouth and your throat, etc. Another thing that I often get with dry powder inhalers is that it's not working because I'm feeling the powder in my mouth. That's what I get sometimes. Actually, the way these are designed, with generally lactose as a carrier agent for the drug, and when the patient inhales, that quick and deep inhalation that they need to use with the dry powder inhaler, what they're doing is kind of creating the vortex that's disaggregating the powder and creating the aerosol that they're going to inhale. It separates the drug from the lactose, because the lactose is quite big, heavy particles, but the drug is a much smaller, lighter particle. That's the particle that goes down into the lungs where we want it to be, but quite often the heavier particle, the lactose, stays in people's mouths. So they'll describe having like a powdery feeling in their mouth or a taste in their mouth. That's absolutely fine. And I think it's really important to explain that to patients. Rinse your mouth out, and you know, but if you do feel powder, that doesn't mean that the inhaler's not working or you're not getting the drug into your airways. So thinking about the benefits of MART, maintenance and reliever therapy, as I mentioned right at the very start, MART's been around for 18 years, so you can imagine there's a huge array of studies that have been done on MART, but they highlight to us reduced exacerbations, reduced oral corticosteroid use, reduced hospital admissions, just so many benefits. And one study that I pick out is the MART-2 study that was done on beclomethasone for Motorol, and that highlighted that the average daily dose of MART was 2.8 puffs of the inhaler daily, so not you know, huge amounts of steroid being used. Again, it's one inhaler, it's simple, it's one prescription charge, and it doesn't completely rely on them having to be compliant with their daily dose, because even if they forget to take that morning or night time dose, they're using that inhaler as their reliever, so they're still getting some steroid and treatment for their asthma. MART is for people with more frequent symptoms, so anyone who's having to use a reliever inhaler 3 or more times a week, or getting symptoms 3 or more times a week, or waking up with their asthma. You know, MART is probably where we would go into treatment rather than going on anti-inflammatory reliever therapy for those. And as I've mentioned, it can be used from 12, but it's those budesonide for Motorol combination inhalers that are licensed from 12. The beclomethasone for Motorol ones are licensed from 18. So just thinking about some top tips. Remember SAD-SABA when we're talking about asthma. Always remember SAD-SABA. No SABA monotherapy. That's what the guidelines are very, very clearly saying to us. That's what the MHRA have said to us. That's what GINA are saying to us. Everybody is now singing off the same hymn sheet when it comes to this. There should be nobody out there managed on SABA monotherapy. And we need to sort of think about whether they are excessively using that SABA alongside any other treatment, and remember that pathway that kind of shifts people over to maintenance and reliever therapy if necessary. Have a look at the summary product characteristics for each of the different inhalers that I've talked about tonight, and become familiar with them, because they have their nuances and slight differences in daily maximum doses, etc. One of the things that I always get asked about is around emergencies. So emergencies, these ICS and Motorol combination inhalers can be used in the event of an acute asthma attack and in the event of an emergency. The license is for up to 6 puffs, usually around 1 to 3 minute intervals. My advice to somebody who was having an asthma attack would be take 1 puff at 1 to 3 minute intervals, up to 6. If you've got to the point where you've used 6 puffs and you are still symptomatic and you're not getting better, 999. Whilst you're waiting for an ambulance to come, you can repeat that step of up to 6 puffs. Now, people, often pharmacists, will say to me that might take them over the maximum licensed daily dose of their ICS for Motorol containing inhaler. I don't really care at this point. If somebody is heading towards an admission for their asthma and their asthma is so severe, the tiny extra doses of inhaled corticosteroid that we're going to be giving them on a one-off occasion, to me, keeping their airway open is much more important. So that's where I think we kind of sit with that one. Personalised asthma action plans are so important. They are, if somebody has a personalised asthma action plan that's specific to the regime that they're taking, so if they have a MART one, this one is the Primary Care Respiratory Society's one that I was involved in developing, and very proud of it, actually. You know, it's got a lot of useful advice and education, and if we sit and we go through this with the patient and they know exactly what to do in the event of an emergency, you're 4 times less likely to end up in hospital as a result of your asthma. If you have a plan, that's how important they are. Think about your sales pitch. So think about your own confidence in ICS formoterol combination inhalers. Think about how you are going to talk to patients about them and how you're going to convince patients that these are safe and these are the right thing to do for their asthma. And remember that upgrade. So we're upgrading, we're not taking away. And hopefully, if we're all singing off the same hymn sheet, in another 10 years, I will not be standing here talking about poor asthma outcomes in the UK. I'll be saying, wow, look at the fact that our asthma deaths have reduced so much in the last 10 years. We've really made that difference that counted for our asthma patients. So that is the end of my presentation. I'm more than happy to have a chat or answer any questions that you've got. It's a bit of a whistle-stop talk because there's a lot to talk about. But has anyone got any questions?
If I can say, Deborah, I don't have questions. It's been very, very good and very informative session. I would just say it's sad that it took so many years for everyone to realize that MART is the way forward. So we had these combinations like 18 years ago, and we didn't look into it at the right time. And I think unless it's very well said, sometimes GPs are still reluctant into going into this MART, and they're still preferring the separate combination and salbutamol.
Yeah.
And so, as you said, hopefully in 10 years we'll be seeing less of needless deaths from poorly controlled asthma, and more of MART prescribing rather than separate. Because I'm working for mental health services, but sometimes physical health deterioration can affect the mental health, and I still see, unfortunately, Foster and salbutamol separately, or Clenil Modulite and salbutamol separately. So hopefully we will be able to see more of that, and maybe like having more pharmacists as well, graduating as independent prescribers, maybe having that scope of practice as respiratory. We need more people to be reviewed and getting on the right therapy. That's what I wanted to say. Thank you very much.
That's a really lovely observation, and I totally agree with you with the sadness that it's taken so long. We have approximately 4 people die every day in the UK as a result of asthma, and they are mostly preventable deaths. So it is very, very sad. But I'm hoping this is the shift now. You know, everybody is saying the same thing finally. So one of the things that I'm kind of tasked with is our ICB-wide guidelines. So I'm currently in the process of developing our children and young people's guideline to go ICB-wide, which will hopefully help clarify things for GPs. Because one of the things that we often find is, because the GPs deal with a kind of acute stuff, and it's a lot of the nurses or pharmacists in practices these days that are doing a lot of the chronic disease management, is that sometimes it can fail because GPs might not realise that they shouldn't have a salbutamol alongside these regimes, and that gets restarted again, and so the problem just is perpetuated. So to try and get everybody singing off the same hymn sheet in kind of every touch point, there's a lot of work that needs to be done. But the children and young people's guidance, once we've got that approved and agreed, that the adult one will come off the back of that as well. So hopefully within the next few months we'll have that out, and we'll have the whole ICB with the same guidelines. So it should be quite clear then what should be happening. But I think what I didn't make clear was that was the point, that these flexible dosing regimes, people shouldn't have salbutamol alongside them. It totally defeats the object of these treatment regimes. The idea of it is that, you escalate your steroid dose, you dampen down that inflammation, you reduce the exacerbation risk. If somebody is given a salbutamol alongside it, well, they just revert to using the salbutamol like they'd always do, when they puff on their salbutamol, and they might feel better for a minute or so, but then they need it again and they need it again. And that inflammation just continues to rise, and to the point where they need oral corticosteroids and they've had an exacerbation. So by giving salbutamol alongside it, we're just completely defeating the benefit of air and MART regimes. So we should really, really try and make these regimes SABA-free wherever we possibly can. And it's interesting that you mentioned about the pharmacists coming out as independent prescribers from their degrees, and I think that's a really, really important point. So I was actually at a parliamentary reception last night, which was hosted by the Task Force for Lung Health and Community Pharmacy England, and it was around what community pharmacy can offer to respiratory care and lung health, and some of the things that were talked about there was increased access to vaccinations, smoking cessation service, like a national smoking cessation service for community pharmacy. But the third thing was annual asthma reviews being carried out in community pharmacy, and inhaler checks and prescribing for asthma. And I think that community pharmacy is a great place to be able to capture these people, because the asthma patients just don't tend to turn up for their asthma reviews, because if they're well at the moment in time where they get invited for the review, they think, oh, I don't really need a review, I'll not bother. Whereas they have to walk into the community pharmacy to get their prescription. So it's an ideal opportunity to capture people for that. One of my concerns is that I'm still seeing a lot of newly qualified pharmacists coming out with not up-to-date information, so they're still being taught the old BTS guidelines. That's a kind of task of mine, to think about how we can improve the education. And it's not isolated to pharmacy education, by the way. It's the same for nursing, and it's the same for medics as well. They're all still being taught the old stuff. So we need to really try and shift that, because if these people are coming out of university fresh with their prescribing qualification and chomping at the bit to do these things, but the information that they've been taught at university is incorrect, we risk causing the problem, because again, we're not singing off the same hymn sheet. So yeah, lots to do. I think there's lots of touch points of this guideline. A&E is another one that we're going to have to do some work with, because A&E will just give them a salbutamol and send them out. I'm starting work with one A&E in Barnsley are wanting to do some work on this, and so we're going to try and have SABA-free discharge in the 12 and aboves for asthma admissions to A&E. There's going to be a lot of change for them, and so there's going to be a lot of work involved in it. But if we can make it happen somewhere, we can hopefully get the other A&Es to kind of join in as well. Out of hours services is another one as well. Lots of different touch points where it can fall apart if everybody's not doing the same thing.
Yeah, but as you said, at least if the reviews would be done by properly trained pharmacists, then we should be better in prescribing, as in like cost effective and safe for the patient after all. So
Yeah.
hopefully.
Fab. We just need to make sure that every newly qualified pharmacist that comes out watches this recording afterwards, and so they're all like doing the right thing from the start. So if there's no other questions, happy to kind of call it a day now. I am more than happy for people to email me if they have any questions. It's deborah.lees@nhs.net. My name and spelling's on the screen, so anyone can drop me any questions that they might have regarding any of this afterwards. And I'm sure Claire, let me know if there's a desire for me to do one for children, specifically on children, because we've got some slight differences in that age range.
I will do. And thanks, Deb. I just want to say thank you so much for giving up your evening this evening. That's been one of the best sessions that I've sat through in a long time. It really, really was very, very well presented. It absolutely spot on. So, you know, we absolutely will be promoting this to anyone. And I know it might be some time before we do see something through the national contractual framework for our community pharmacists in order to be prescribing and supporting our asthma patients better. But I'd absolutely love to pick up a conversation around what perhaps we could explore locally in the meantime. So we'll pick that up offline. But thank you everybody for joining this evening. I'll stop the recording now, but if you do want to get in touch with Deb or myself, my email address is claire.thomas47@nhs.net. So please do get in touch and enjoy the rest of the, well, very fading sunshine.
Thank you. Thank you, you too. Thank you.
Take care, everyone.
Thank you. Bye-bye.